So the musculoskeletal, so this affects everybody you know. And this is, to me, one of the easier systems to do because it's the obvious. You're going to see it on your patients so much easier. As far as, we've got a nice normal vertebrae, okay, on the left. Do you see that one on the bottom there, bottom left? And then osteoporosis on the right, so that bone density is just gone. Primary things we're going to do this chapter is cellular regulation and then mobility. Okay? As far as the cellular regulation, we'll see the osteoporosis, or we'll see bone tumors in the young adolescents, or bone infections and deformities. And those all happen with that cellular level. And what it's going to do is going to affect their mobility because they are in pain. Okay? And they're in pain. Sometimes they don't have enough blood flow to that area, enough perfusion, and so it's impaired. Common and contrasting characteristics. You always ask your patient's history, right? It'll affect this. You know, there are going to be some things that are going to be genetics that are going to affect their bones. Their culture, because that's also going to have a play on what they're doing, where they are, and their diet. You know, like you said, osteoporosis is definitely one with the diet. You will be able to see things, physical signs and symptoms on the patient. Okay, cellular regulation causes decreased bone density and possible fracture. Osteomalacia is the lack of vitamin D, which causes softening. If we don't have enough vitamin D, it causes softening. Bone remodeling is the living, changing tissue. Osteopenia, the loss of bone mass. And the bone mineral density is the amount of minerals will determine the strength. A lot of you are right there, or almost there. Your bone strength peaks at 25 to 30 years. Okay. When we think about our cellular regulation and the decreased density, it puts the patient at a possible risk for fractures. Because those bones are fragile. Females with the hip fracture are at increased risk 2 times over men. But men typically die more. Hip fractures increase your mortality within 6 to 12 months. So if you hear somebody say, oh no, they got a hip fracture, oh, you're thinking, okay, we can fix that surgery. But it's an elderly patient. Typically, they have definitely an increased chance of mortality within that first year. Cancellous, or spongy bone, is always lost first. Then they're going to lose their cortical, the compact bone. So cancellous is the spongy bone. Then they lose the cortical, which is the compact bone. You'll notice this first in the hips, in the wrists, and the spinal column. All right. Look at that beautiful spine there. Normal spine, somebody at 40, 60, and then 70. We were talking about, does anybody remember what this little hump right here is? Kyphosis. Yeah? Okay. This talks about at least 6, it can be as much as 6 inches in height. Okay? So osteoporosis is generalized. It's primary female postmenopausal. In males, it's the 7th and 8th decade of life. Secondary osteoporosis is other medical conditions caused by their osteoporosis. Okay? A lot of people will use corticosteroids because then they can, it'll keep their prolonged decreased mobility. They can keep them going. Spinal cord injuries. If they have regional osteoporosis, instead it's localized to one area. The limb is immobilized, which could be like a fracture. They may have a brace or paralysis. What kind of things can we do to help prevent osteoporosis? Vitamin D, which is going to help us be able to absorb the calcium, right? What kind of other things can we encourage people to do daily? Exercise, okay, and weight bearing. So like the walking. Do we encourage running for osteoporosis? No, increases their chance of breaking. Smoking cessation. Smoking is a very, very bad thing for all body systems. We got to limit their alcohol. We don't want them to get impaired and then fall. Right? No. Plus, it's for absorption, right? We don't want them to fill their calories with that instead of something better. And decrease your carbonated beverages. Alterations in the growth hormone itself, they have found in petite Asian American women. So the little tiny, tiny women are the ones that have the most problem with this. All right. Nutritionally, the calcium loss will increase with high intake of phosphorus. So they do not suggest soda whites. Anybody have any idea? A large intake of soda, they do not want you to have over 40 ounces of a carbonated beverage per day. Puts you at high risk. Calcium loss increases with phosphorus. Yep. Calcium loss. So if calcium is going down, this phosphorus goes up. Okay. There are protein deficiencies that affect the calcium, and 50% of the calcium is bound to protein. What is a gravity-free environment? Can you think of somebody that works in a gravity-free environment that would be at risk for osteoporosis in a localized area? Astronauts, there you go. You don't think of them with osteoporosis, but yes, because they're in a gravity-free environment, they're not doing the weight bearing. So, yeah, it does, but it's not something you would just think of. Okay. So we're going to do a fall risk assessment on these people. We want to see what's their chances of falling. Falling, you're going to break things, potentially. Okay. As far as we've talked about the humpback, we saw kyphosis. And the book said 2 to 3 inches. Our slide said 6 inches within the previous 20 years. The most common spinal fracture is between T8 and L3, or the upper third of the femur, or the distal end of the radial wrist. Okay? Those are our most common fractures. Calcium should be, what's our normal range for calcium in the body? 9 to 10.5. Vitamin D, we're 8.5 to 10. Okay, your textbook says 9 to 10.5. I'll take 8.5 to 10. but we're putting it right in the range, right? We are right there, though. So that puts them off a half point, right? 8.5 or 9 to 10 to 10.5. Let's see. Are you Googling it for me?
I'm not, but I can. That's just what we were right? Yeah. Okay.
See? That's good, because this textbook, the new textbook here, says 9 to 10.5. Okay?
It says 8.6 to 10.3.
So it's right smack in the middle of the other two, between what you've been given and then what this textbook says. All right. So 8.5 to 10.5 would cover all. Right? Okay, vitamin D. What kind of levels do you have for that? What would be our normal lab test for that? I have 25 to 80. Okay? All right. When we're talking about, so those are the laboratory tests we're concerned about. The dual X-ray, the DXA, they like to do this in females in their late 40s for a baseline to see where they're starting. And what that's going to do is check that spine, hip, and wrist for the bone density at that point. So we're looking for the volume of bone density and the strength of the vertebral spine and hip. All right. Biggest problem is potential for fractures due to weak porous bone. So we just want to avoid fractures, prevent falls, manage the risk factors, and adhere to preventative treatment. Can somebody give me just one thing you would want to do in an elderly, tiny female's home? She's living on her own. What would be one thing you would want to do in her home to prevent a fall?
No floor mats.
Take the rugs out.
Take the rugs out. There you go. Take the rugs out. Got everybody? Sweet. Thank you. Okay, planning and implementation. So we were talking just a minute ago about safety precautions, so take the rugs out. Absolutely. Drug therapies that we can do for these are biphosphonates, because those slow bone resorption, and they help form new bone tissue. You want to avoid excessive alcohol and caffeine consumption. We're going to eat and drink calcium and vitamin D foods, especially ones that are enriched. Typically now we have it in our milk and bread and orange juice and cereal. So we have a lot of things that are already done for us. Okay. And the other thing is they need a variety of nutrients. Not just the calcium and the vitamin D. So we have to make sure that they've got fruits and vegetables and low-fat milk products, protein, and increased fiber. Things that we don't want, like you heard, no tobacco. Postmenopausal women over what age, typically? Over 40. Postmenopausal men at what age? 70 to 80s. And it can happen as early as 50s. And we want what a minimum, how much calcium intake did we want? We looked at that chart last week. So on average, you would want at least over 1,000, if not 1,200 milligrams per day. What kind of physical therapy, what kind of exercises? Weight bearing and strengthening. So they can go to the gym and they can do light weights, different repetitions. We want to make sure we keep the abdominal muscles in the back because we want to keep their posture improved. And we have to support that spine. Swimming is excellent, and so is yoga. Has anybody ever been in the YMCA and you see these little ladies come in? They're there for yoga class. But it's done so much better. We have a lot of younger people coming for yoga too. And so no running and no horseback riding. Okay, that's another one. It's not a good thing. Okay, osteomyelitis. This is nasty stuff. This gets very, very difficult to take care of. So it's an infection in the bony tissue. You know, and it's getting in there to take care of it. So this can be caused by bacteria, viruses, fungi, or parasites or maggots. Has anybody ever seen maggots in a wound? Have you? Yeah. And actually sometimes that saves the patient, right? It does, because it's eating off some of that necrotic tissue until we can get them the right help and get it cleaned out and get it dressed. And yes. So sometimes you have a patient come in the ER and they have, you know, you can see this wound. They may have a bunch of flies or they may have actually maggots. But sometimes that has actually saved them because it's eating away that infection for them. So as gross as it is, it's like, okay, you can't do the trick. So exogenous versus endogenous. Exogenous, endogenous. So those are our ones outside the body. The endogenous are the ones carried in our bloodstream. And what the problem is these microorganisms stimulate the inflammatory response in the bone tissue. That increases the vascular leaking and edema in the blood vessels. With that increased volume, it becomes pus. They release pus into the bony tissue and it becomes necrotic. So that is why we can't let that bone die. A contiguous bone infection is from the skin infection of adjacent tissues. I mean, there was a clinical patient last night. I don't know if you had him on day shift. He was a motor vehicle accident that had a nasty cellulitis of his left foot. But the bottom line is he had so many scabs and things all over that I could see that coming from infection, that it could be a contiguous, you know, from the skin on down. Anybody have him on day shift? Did you? Okay, so you had him. So can you, I mean, he would be the perfect example. Did anybody else in your clinical group get to see him? Sarah did? I mean, you think about it, he had all these issues on his skin, but if they weren't treated, and you know, he had a huge medical history that this guy, there were so many things to treat. It was kind of like, where do you start with them? So he did. So let's see. You were in that room too, weren't you, Holly? Mm-hmm. Okay, I was thinking. Yep, he was pretty much a mess. And at one point in time, we were in there, I was concerned that he was getting septic because his respirations at one point in time were up to 32. His temperature was dropping. His heart rate and respirations were going up. I'm like, is this guy getting septic on us? He might, yeah. He didn't look good for a while, but he got better.
He was normal the whole time I was there. His vitals were.
His vitals were? Make sure this is on. Okay. But he would be a perfect example of this. Okay, so we have acute osteomyelitis versus chronic osteomyelitis. The acute is usually a bacteremia, is the underlying disease, and it's a non-penetrating trauma. A chronic osteomyelitis is misdiagnosed or inadequately treated, like foot ulcers, or it could be salmonella to the GI tract, and then it will go to the bone. Patients with sickle cell anemia. Where do I want to go? A lot of people don't think about poor dental hygiene. So they can get periodontal disease, periodontal infections in the gums, and then it can go right into the bone there. Some people get these after surgery. So it can be most common as MRSA from surgery implants. And even older gentlemen, and it's males in particular, if they have a UTI, it can spread to the lower vertebrae. So these people will need long-term IV catheters. You know, they'll need PICC lines to get this, but long-term IV catheters can also be the primary source of an infection. Things I want you to look for is bone pain or a fever over 101, swelling, tenderness, redness, and heat. So that's in an acute system. If they have a chronic osteomyelitis, it's harder to determine because they have less symptoms. They've dealt with it so long and the body doesn't respond the same. Those are the foot ulcers, bone surgeries, localized pain. So with the chronic, the vascular compromise is severe. They don't, and a lot of them don't have pain. And that is due to the nerve damage from a lack of adequate perfusion. Okay, the ESR, their SED rate. Anybody know what that happens with osteomyelitis? It's going to be normal at first, and it's going to increase. It's going to increase as it progresses. They'll have an elevated white count. It takes a minimum of 4 to 6 weeks of IV therapy, and they have to do it at the specific time. It's very important you do it at the specific time. If they have a chronic osteomyelitis, they will do over 3 months of IV antibiotics. A lot of times you are teaching the families how to do these IV antibiotics at home. Okay, one of the things that Maza got to do yesterday in the pain clinic, or I'm sorry, not pain, wound. Who else in here has been to wound? Okay, that hyperbaric chamber. All right, and what's that going to do? You did a good job of describing it yesterday, Maza, would you?
Increases like oxygen that the patient gets, and that will stimulate like healing.
That oxygen goes right into those tissues to promote healing, correct? It's very helpful with the anaerobic infections. A lot of these patients, what kind of precautions are they going to be on at the hospital? What kind of isolation precautions? Contact. Mm-hmm. So do we have to wear goggles for that? No? Gloves and gown. And unfortunately, I will tell you that with COVID in the hospital setting, we needed all the gowns we had for COVID. We had such a shortage of gowns. And MRSA just kind of got left by the wayside. It was horrible. And so those people, other people that were in the hospital, like you said, you don't want to be in the hospital because you don't want to catch COVID. But if you had somebody that had MRSA and it got carried from the other room because you weren't being, it was not as protective of an environment. So that did change and go back once we got gowns. But when we didn't have enough and we were reusing gowns, the only patients that had gowns were C. diff. So, yeah, just a sidebar note on that. A lot of times we do an I&D, incision and drainage on these people. They'll have lots of wound debridements and bone excisions. Sometimes they will, if they can open them up, they will do, you'll see that they can do IV antibiotics, but not just liquid antibiotics. They will go ahead and flush that wound And if we can't get the bone to heal in the carotid tissue, we'll remove it surgically, and then there will be a cavity or a hole. And sometimes they have to replace with bone grafts. The most common sites you would use is the fibula and the iliac crest. What do we really want to be looking for on these patients if it's anything in an extremity? Blood clots, okay. The assessment you really want to know, that's correct too, blood clots, because they're not moving. Anybody that's not moving adequately. But their neuro assessment. I'm going to show you a picture, unless I just lost it. Hopefully I didn't. Okay. I'm sorry I don't have a bigger picture of this. But my son, and this is from him, I'll show you too. He had a guy come in to the ER, and he had a dog bite. This dog bite took off his toe.
Oh my gosh.
Okay? He put Scooby-Doo on there. He put ruh-roh. And so there's the bone. Look at the bone is gone. I'll show you guys this one too. Everybody, sorry I don't have a bigger picture.
How old was your son when that happened?
Huh?
How old was your son when that happened?
He was probably 28. I think he's 29 now.
The dog took off his toe?
No, his patient. My son was working the ER.
Oh,
podiatrist.
thank you.
Sorry about that. So podiatrist. Sorry about that.
Oh my gosh.
Ruh-roh, Shaggy. Now, this is what it looked like. And he put on here, when your dog thinks your foot is a Scooby snack.
Oh gosh.
Oh.
Now this
You don't
guy,
get the dogs to eat you. Those are the ones you don't try.
I'm telling you, so this was in December. Isn't that amazing? But why did this happen to this patient? He did not have any feeling. He woke up to the dog. He slept through it.
There's also something wrong with that dog.
There's something wrong with the dog. Why was the dog attracted to this?
Exactly.
Probably because he had an infection.
He had an infection. And that caused the stink and the smell, caused the dog to be attracted to it. I mean, yeah. And so he woke up to his toe being gone and this dog chewing on his foot. Isn't that
He
crazy?
had to be a diabetic, right?
He was not. He was not a
He had
diabetic.
neuropathy.
He had neuropathy, regardless. He had neuropathy. So, but I mean,
Undiagnosed diabetic?
no, not quite, because that's what I was like. I asked my son all these questions, like, no, Mom, no,
Sure.
no. So yeah, it was quite something. I've got a few other pictures from him too that we'll show today. But yeah, I was like, oh my. So he sends me fun things like that when he's doing stuff. All right, so we talked about bone pain and fever, and the IV therapy. So how long is it if they're chronic?
4 to 6 weeks.
Mm-hmm. And how long is it if it's acute? 4 to 6 weeks typically. Chronic for acute, and chronic is over 3 months. Okay? And acute has a lot of that bone pain and fever. Chronic can have bone pain, but it's not, it's not something new, so they don't think as much about it.
I have a question. So
Sure.
That patient, did he tell you he had like a bone spur that was sticking out of that? The cellulitis?
This patient, that my son,
No. The one from yesterday.
the one from yesterday. Okay.
Did you see that?
The bone spur.
He said he had a bone spur and he like pointed at it. I couldn't like tell because there was like
So much swelling.
busted drainage and stuff. But
He did.
would that have caused like an increased risk for this? Since if it was there, I couldn't tell.
If there was a bone spur,
He said it was like
increase.
sticky, usually stuck out of his skin. I didn't really think I saw anything. Did you see it?
I didn't see that. I think it might have been too swollen at that time. I mean, Jesse from Wound Care came in and he was like, that whole leg was red and fiery. It was, and it was swollen, the whole thing. And after you left, that foot just blew up like a balloon. toes are here as you come up, okay, and this would be the heel under here. Like right here, one foot was like this at that point on the body. And on the other, it was about like this. That's how much he was swollen. It'll be interesting to see if he gets to keep it. Yes. Yeah.
His foot or his leg?
What's that?
His foot or leg?
That was his foot. So like I said, it's like if your toes, my fingernails are his toenails, and this is the heel right here. About right, like 2 inches up. And on one, if the circumference would be like this on his regular foot, and the other one was like this. I'm not exaggerating, am I? It was massively. I don't think.
You think he's going to lose from like the calf down or just the foot?
It depends on the vascularity and how much they can keep alive. Okay, but I would be surprised if he stayed there all night, though. Just because, like I said, I thought he was starting to get septic, and I actually told the nurse. I ran her down and said, "Hey, we're gonna."
We had a situation at Barnes Jewish in the psych unit. A man who was mentally ill was wandering in downtown. It was at night. He got hit twice, so he had 2 fractures. They repaired the fractures. He was to stay on bed rest, was non-compliant. They wound up having to commit him over to the psych unit. I could smell the decay when I walked down the hallway at psych. You don't smell decay in a psych unit. They wound up having to commit him and amputate his arm. So the staff were sick about it. But he was necrotic and he was going to be settled.
There are certain smells you will learn right away, and that's even through an N95. Right? The other one, you will smell that, you will smell a GI bleed. Once you smell that, you won't ever forget that one either. Let's put it this way, I had a patient on Friday, it was my patient with a GI bleed, and his wife came, she walked in, she's like, oh, and she had to step out of the room. I said, are you okay? I will be. And she left. And she came back and she said, I put stuff in my nose. I don't know how you girls do that, but I stuffed tissues up in my nose so I can't smell this. Because it was that bad. And then later on, when I had to get him up back to the bedside, when I was giving this gentleman blood, he was bleeding out pretty well. It's an ICU. And he started to get over to the bedside commode again, and his wife said, I think it's time for me to go to Walmart. She was gone. I'll be back. She was gone another couple hours because she just could not handle the smell. At the end of the day, the intensivist came over. He goes, I bet you just wish you had COVID all day so you didn't have to smell. I'm like, it's bad, but I'm okay with it, So yes, you will get smells and you will get accustomed to different things. You will know as soon as you enter the room. Or if you're working in the ER, you already know. Right, Nadia? Yep. You know, like, immediately that something is going on. Because it's not a smell they can take care of. All right, let's go on to bone tumors. So we have benign versus cancerous. Okay, benign ones are often asymptomatic, and they can be discovered on a routine x-ray or as a cause of a fracture. Thing with bone cancer is the patient has a ton of fear, and they should because they're losing control of their life, and it could be very fatal. The most common places for these fractures, of course, are the femur and the tibia. Young people, ages 10 to 30, have a small amount of bone cancer. It does happen. It does happen. I remember one of my sons was 1, and we had to get a surgery done that we knew was a birth defect, and he was in surgery for 6 hours. And these people came back that you're in this waiting room, and you don't know what anybody else has. And actually, I saw him on the elevator. I was on because I went down to get some lunch, and they said, "You're still here?" And I said, "Yes." "You were here before us." I said, "Yes." My son's still in surgery. And they were like feeling bad for me. And instead, they said, well, ours is done. Our son has bone cancer. Yes. And it was just like, I'll take that 6-hour surgery. Mine's getting better. You know, mine's going to be fixed. But that bone cancer you can't fix. So that just not your stomach is difficult. Okay, metastatic lesions are most common in the older age group, but metastatic lesions happen most in bone cancers. And osteosarcoma is the most common primary malignant bone tumor. And over 50% of the osteosarcomas are in the distal femur. This can cause acute pain and swelling, warm. It's really warm related to the increasing blood flow because it's feeding that cancer. Okay? If they have cancer in the pelvis, it is a very poor prognosis, very poor sign, because a lot of times it will extend into the soft tissue. They have found in the children and young adults that males have a bigger risk of cancer than females. Chondrosarcoma is dull ache and swelling, but that's what they have, but a better prognosis, the chondrosarcomas. The Ewing sarcomas are not as common, but they are the most malignant. So they have low-grade temps, leukocytosis, fatigue, pallor, anemia. Okay? Not fun stuff. Cancer hits the bone. People are usually in bad trouble. Okay, our benign bone tumors. What are we going to do for these people? We're going to make them as comfortable as we can. So non-drug pain relief measures. Can you give me an example of a non-drug pain reliever? Massage. I love massages. Massages, music therapy, aromatherapy, things like that. And the drug of choice for these are analgesics or NSAIDs. And they can have NSAIDs because it's not their GI tract. Remember, we can't give any NSAIDs with anybody with a stomach problem or any GI tract problem. You might want to remember that. So we're going to give it NSAIDs for pain, but not with anybody with, not if they're pregnant and not if they have any GI symptoms. Okay. As far as surgical treatment, what we can do with the joint replacement, what they'll be doing is it prevents further bone destruction, and it might improve the patient function. Sometimes we do palliative care versus a cure for these people. What I mean by palliative care, anybody in here know what palliative care is? It's a huge thing in hospitals that physicians are just now coming on board with. Okay, you've heard of hospice, right? Hospice means that we think the patient is going to die within the next 6 months. We can send them home and we can give them all the things they need and the meds they need to be comfortable. Palliative care is you have a diagnosis. Doesn't mean you're dying from it. But palliative care is you've decided you're not going to make a big change in your treatments. You don't want to keep coming back into the hospital all the time. So basically we give you what you need to live at home. The palliative care could go 2 to 5 years. You know, it can last a while. So you have a chronic CHF or congestive heart failure. That patients, if we get them in palliative care, that can prevent repeated admissions to the hospital. They'll have somebody checking on them, making sure that they're following their routine, instead of nobody checking on them, and then they eat a bunch of ham, they increase their swelling and all the fluid in the heart, that type of thing. So palliative care will keep this patient out of the hospital, keep them comfortable. Okay? And now that's if they choose not to do further treatment. Let's see here. CTs and MRIs is how we're going to diagnose these. And the metastatic lesions will either increase or decrease the bone density depending on if you're doing the osteoblastic or osteoclastic cells, which ones are up. They will do a needle biopsy on the bone to stage the biopsy to see how labor get met. Elevated alkaline phosphate levels will happen, and their SED rate will increase related to the a secondary infection of that bone. A lot of times you'll see a rating of a scale TNM. So that's the tumor. They're rating the tumor, they're rating the nodes, the lymph nodes, and they're rating the metastasis. Okay? For pain relief for these people, what can we do for pain relief for these people? Besides the NSAIDs on the ones with bone cancer. There you go, radiation, chemotherapy. So that causes pain relief for them, and it will shrink the malignant tumors. And you can do chemo with or without radiation. And what is chemo basically? Anybody know? What's chemotherapy? Chemotherapy is a killer. It's going to kill the cells of the body. What we hope to do with chemotherapy is kill the cancer cells, the bad ones. But along with that, it's killing good cells too. That's why nutrition is imperative for these people on chemo. Okay, what we're going to do. What do you think the psychosocial resources, what do we need to do for these people? We need to keep that in mind. We're going to need to make sure, do they have something for depression? Do they have something for their mood? Do they have anything that we can help them with? I don't know. Anybody in here think they wouldn't be depressed if we were diagnosed with metastatic bone cancer? I mean, I think that would be almost everybody. Like I said, they can use radiation for pain control to give a better life. All right. Let's just stand up and take a break for just a few minutes. And then I'm going to go ahead. I'm going to use the restroom here real quick. We get started hopefully in about 6 or 7 minutes. Let's go ahead. All right. Questions so far? I didn't even ask. Okay. Other musculoskeletal disorders. All right. On the hand, Putrin's contracture. Okay, so that is the thickening of the palmar fascia, and so it causes flexion. And these, the fifth and fourth finger, and sometimes part of the third finger is affected, but their hand will not look normal. Okay, and so they don't have as much. They can't bring this back up. They won't be able to do this with the hand. This will be. Okay, and for that they have to do a surgical release because it's the flexion of the fourth and fifth digits, sometimes a third. Happens frequently in older Euro-American men, occurs in families, and it's common with diabetes. And the other thing is it can be bilateral. Okay. A ganglion is a round, benign cyst. Has anybody seen one of these? There you go. Looks strange, doesn't it? Like, man, it looks like it really hurts.
I have one.
You have one. Do you have one we can show? For show and tell?
Do you whack the family Bible with it?
No,
So
I
my
got it cut
mother-in-law
out.
used to do.
Uh-huh.
Break it?
I
Yeah.
have
Break it up,
another one,
yeah.
I guess, but it's kind of over the scar,
Mm-hmm.
so, but it's there.
Yeah, you can see. Can you guys see that
You
in her
had that
wrist?
removed?
I had one removed, and then another one came up right next to it.
Yeah.
So can you show us your other one so we can see? Yeah.
Oh.
You can everybody see the difference? Where'd you go? I don't have them to show. Okay. So the thing is, this happens at the wrist, the foot joints, or the tendons. And the cool thing of that, so it's not, by any means, it's not fatal, right? And so we've got this swelling, and we've got all these tissues that are inflamed. And it causes a problem if it intervenes with the nerves. Too bad. But when she was talking about thumping the family Bible on it, that it works. Bottom line is it takes that bursa and it expels it. I mean, it's going to burst it open. It's going to burst the bursa, okay? And it'll disperse among the cells, and it doesn't usually come back. But with surgical, yes, a lot of things
Yeah,
can come back.
there's one next to where the other one was.
Oh, really?
Yeah.
Did they tell you that after surgery too?
No, it came back like a couple months after.
A couple months after.
But this one, the one that I got cut out was pressing up against the nerve,
Uh-huh.
so I got it cut out. But the other one, I don't get it.
Doesn't bother you because it's not compressing the nerve. Okay, cool. All right, we have this one, the different foot deformities. I want to make sure you know that hallux valgus deformity. Hallux, Hallux, valgus deformity. And it's like a bunion. Okay? And with the bunions, what do people get to have? What's a bunion look like? Bottom line is, here's our foot and our big toe, okay? It's going to go out like this. And so that joint is going to, the great toe drifts laterally and at the first metatarsal.
Can bunions occur on the outside of the pinky toe? On that side of the foot?
Not typically. I mean, I guess it could, but the hallux valgus one. All right, and they say those come from, it's more in females than males. Poorly fitted shoes, especially narrow toes or high heels. They may have a history of arthritis. Okay? And then the other thing that they can get is a hammer toe. And that's the dorsiflexion of the metatarsal joint. So this, like they'll have their toes and one's up on top. And it's most common on the second toe. Okay, here's another one. So this is surgery that they did to fix, you can see they had to cut and shave for the bunion. And then there's for the hammer toe. If you look, here's the wire in that actual toe that they've got sticking out. There's the wire going in the toe that they had to get that straightened out. Where did I lose it? So you can see where they shave for the bunion, you can see the wire sticking out. So if you take care of somebody that has to have a hammer toe, you can see the wire sticking out. That's my mom after her surgery. Sorry. I had sent my mom's post-op pictures to my son. Does that make sense? This is the wire that they did to straighten the toe, the hammer toe. I didn't show you guys this one. Here's, everybody turn around here. Here's another picture of the hammer toe, the wire, how they get it all down deep so they can. you can see all these fun pictures. Here we go, ladies. Brenda, can you see here? So you can see where they shave off the bunion. You can see that wire down through the toe. So they can get it all straight. Did you want to see our fun pictures of the hammer toe?
Fun pictures.
I'm taking care of that. Yep. And these were last year's pictures. I don't have new ones of these things. Okay.
We're gonna do a break soon.
We did when you went downstairs about 5 minutes ago.
Okay, then I did talk to you for just a second.
Okay. Another one we need to talk about is that plantar fasciitis. Has anybody ever had plantar fasciitis? It's most common in 15 to 50-year-olds. If you have this, you will know it. It hurts. And it hurts specifically in the morning when you get out of bed. You get out of bed, you're like, oh! And it's a severe pain, okay? So it's under the arch of the foot. Okay? So it's the inflammation of the plantar fascia, the arch of the foot. And so, especially in runners, athletes, middle-aged, and it can be older adults too. One of the things that can cause a problem is obesity or athletes. Rest, ice, stretching exercises. And you'll see several different devices to strap the foot when you go to sleep to maintain the arch. Okay, so let's pretend this is our foot. Okay, and if we have it down, it's fine, all right? We've got our arch. We've got our arch in the foot. But when you go to lay down at night, does your foot stay in this position? Does your foot stay like this in bed?
If you have a tennis shoe on,
Relaxes.
high top.
But even better, so a lot of times, a high-top tennis shoe, instead of having to do the devices, or if they have a boot, a cowboy boot, anything that stabilizes and will keep it up when they go to bed. Why is it important when they go to bed, and why do we have pain in the morning? When you go to sleep, what does your body get to do? It gets to heal. So those fibers will heal in the plantar fascia. But do we want them to heal like this? No, we want it to heal like this because so that's going to stretch them, right? When you stand up in the morning, first of all, you put your weight on it. Okay, so that's going to rip out what you just worked on healing. And that's why you have that excruciating pain in the morning. Okay? Good supportive shoes. Old lady shoes like mine, my Birkenstocks. You will see me in as many Birkenstocks as you can. I learned that after some nice herniated disc. It's very, very helpful. And so pain control, ice pain control, stretching exercises help these people. Sometimes you can actually do cortisone injections for these people, and that might help that, or different surgeries on this musculoskeletal type thing. Plantar fasciitis, they don't usually do surgery for it, unless it comes totally detached. Priority concerns with other muscular disorders. Contractures. Who's had little people, little old ladies, little people with contractures? Anybody? Anybody worked in a nursing home? Anybody seen anybody with contractures? Do we know what it is where they can no longer, even if you tried, you can't even move that arm? It's been so long that they've been maybe in a fetal position, or their hands, you can't get them open. If you can get them open, I'm going to pretend like we've got a washcloth and it's rolled up in a roll. And if you can get that, and you'll see them a lot of times, we'll do this just to even keep from closing all the way. Anything you can do to provide a little movement in there. Because if you go ahead and you yank that, you're going to break it on these little people that are contracted. So you have to really worry about their wounds. Trying to remember whose patient it was yesterday. Little old man. He could move around, do pretty much whatever he wanted. He was real cute. But on the inner aspect of his knee, he had a sore. Whose was that yesterday? Anybody remember? What was yours? Okay. And what was his diagnosis? What was he there for?
Abdominal pain / hernia.
Abdominal pain / hernia. But here he had these little things on his skin. And I said, so what's that from? He goes, oh, I like to lay on my side. If I lay on my side, he goes, it's from rubbing it against the other leg. So his mobility was decreased. And look, here he was getting wounds. And this is a man that can get up and move and do what he wanted. But you could still see. And it was a good quarter-size wound on the inside of his knee. And I said, you need to make sure you put something in between there. You need a pillow between your legs if you're sleeping. And you need at least like 3 layers of a blanket or a towel or something. But some of these little old people, it's not that important to them. Oh, yeah, that's what that's from. So did he have some neuropathy? Could he not feel it? It didn't bother him, But it had been brought to his attention before, but he just didn't really care. Okay, pain. What are we going to give mostly for pain and musculoskeletal disorders? I'm sorry? NSAIDs. Yep. All right. Yep, we talked about the stomach, so we don't want any GI issues or GI bleeding. Mobility, and by the way, I talked about my GI bleed patient. Guess what he had the previous 2 days? NSAIDs brought along his GI bleed. Was there something there before? Probably, and that aggravated the bill. Okay, mobility impairment. So all these people with bone issues, they're going to have mobility problems, and we got to do our very best to get them fixed. Okay, and what we can do, whether it's other devices, is it a walker, is it crutches, what type of thing. Okay, what types of nursing care are common to any of these disorders? So as nursing, what are you going to think about for these patients? I gave you some of it. Comfort. Pain relief. We're going to increase their mobility the best we can, or get them back to full functioning. What are we going to think? So they've got this, bone cancer now. We talked about, we got to remember their psychological portion, how they're feeling about their disease process. And the other, nutrition is extremely important. Right, we talked about nutrition. What about their self-perception, and do they want to be seen by others? Do they want to be seen by others as disabled? Do they want to be seen with this huge foot? Do they want to be seen with problems that are obvious? No. So we got to keep that in mind. All right, we've got a nice case study. 64-year-old woman is seen in the adult outpatient clinic. She was measured as standing 65 inches tall last year. The nurse observes that the patient now measures 64 inches. She has a mild kyphosis. What assessment questions should the nurse ask at this time? We've got the answers at the bottom. What kind of things do you want to ask this patient? Does she feel like she's gotten shorter? Does she have any pain with lifting, bending, stooping? If the pain is worse with activity or relieved by rest. But the other thing is, what other things can we ask? We just talked about a little bit of it. To prevent it from getting worse, what can we make sure her intake is decent of? Calcium. What's she doing with her diet? And what's the other thing to prevent worse osteoporosis? Weight-bearing activity. So she can do some core work. She can do, if she wanted to do some yoga, if she wanted to just make sure she's getting her walking in, using that. But remember, we talked about the spine, so we have to increase your core to take, if you work on your core muscles, what does that do to the spine? It takes the additional weight off of it. So the spine's not working so hard to hold everything up. If these muscles are flaccid, the spine is doing all the work. But if these muscles are taut, embedded, then the spine doesn't have all that weight to support. The muscles are supporting part of it. Okay, the patient is diagnosed with possible osteoporosis. Which diagnostic tests would the nurse anticipate? Phosphorus, serum calcium, thyroid test, okay, to check for hyperthyroidism. And then we've got our DXA, the dual x-ray. And so what is that test checking for? We talked about it earlier today. Bone density and strength, bone strength. And they measure what 3 areas? Wrist, hip, and spine. Okay? And we said that we need to start that if we can in a female age 40. All right, case study. The patient is diagnosed with osteoporosis. Which intervention by the nurse would be appropriate? Most appropriate. That's what makes this one hard. Do we want her to cut down on her cigarette smoking? Yes. Do we want to recommend walking 30 minutes 3 to 5 times a week? Yes. Diet high in protein and calcium but low in vitamin D? No. Tell her to include high-packed activities such as running, mountain climbing, horseback riding? No. None of the above. Okay, so our best answer is the exercise portion. And the problem with the calcium is that they said low in vitamin D. That's what's wrong on that answer. So here's one where smoking, A is a correct answer, and B is a correct answer, but which one is the most important in this aspect is the exercise. And that'll be the majority of the patients, hopefully, anyway. I think a lot of our people are smoking less, hopefully. Next case study. Which patient statement about self-care indicates a need for further teaching by the nurse? I like this one a lot. What's wrong with joining the bowling team? Not really anything wrong with joining it, but to think that that's your exercise. Because that's not going to be a weight bearing. I mean, you are going to hold a bowling ball for a little bit, but that's not going to be long enough, okay? So, do we want them to swim? Yes. Low-fat yogurt, perfect, because that's good calcium and low-fat diet. And my husband's getting rid of our throw rugs. Any comment?
I said that's good. The programs, so they won't fall.
I'm telling you, there's so many people that come in because of throw rugs. That was one of the first things I did when my dad died. He didn't die at throw rugs, but I just knew my mom had a club foot and her stability was not that great. And she had already had falls. So Chief, my dad would call him Chief, had to have the throw rugs down because you couldn't get the carpet bad. Couldn't make the carpet look old. So he had throw rugs on top of carpet. Okay. All down the hallways and that. And so one of the first things I did when my dad was kind of like, okay, time for these to go, Mom. We don't need you falling. You're living on your own, you know. She was like, okay. She didn't complain about it. All right. Provider orders calcium 1.5 grams orally twice a day, 1 gram in the morning and 500 at bedtime. The patient asks why she must drink extra fluids with this medication. What's our best response? Prevents kidney stones? Exactly. Because calcium will cause those kidney stones, but we want to make sure we get calcium in where she needs it. But if we have enough fluid with it, then we won't end up with kidney stones. Okay, she also asked why she can't take it once a day. And what's most important? It should be taken at bedtime. The third dose is most readily utilized by the body when the patient is fasting and immobile. That body's resting and healing. Besides just calcium like that, what's an easy fix for women to get their calcium in? something over the counter that we can take easily, especially if you're taking it at night with your nighttime medications. Tums. Tums are an excellent source of calcium. Will not harm you to take 2 Tums at night. Okay? But that's one of the quickest and easiest ways. You know, I think God designed it. Think about these pregnant women, and they have all this indigestion. And, you know, I remember I lived with Tums in my pocket, and I won't forget why, because I went back after having that first baby to work. I was doing cardiac rehab in the gym, and I put on my jacket, and what did I have? A bottle of Tums still in my pocket. But I went, oh, thank God I don't need these anymore. But yes, because that baby it's going to take a lot of that calcium out of your own body, so it's making sure you get it replaced. All right. Community education program. The nurses asked about the risk of a woman breaking a bone due to osteoporosis after age 50. The nurse knows which of the following is the risk. 1 in 2 women, 1 in 5 women, 1 in 7, 1 in 10. Who wants to read that answer? Pretty nice, huh? 1 in 2 women over the age of 50 will break a bone because of osteoporosis. A woman's risk of breaking a hip due to osteoporosis is equal to her risk of breast, ovarian, and uterine cancer combined. Women have lighter, thinner bones than men. Many women also lose bone quickly after menopause. And what's that bottom part saying? Because I can't read that. Up to 1. Let's see.
1 for men over the age of 50.
Men over the age of 50, and especially in the 7th and 8th decades. Yep. What did we say about a hip fracture? Increased mortality in the 6 to 12 months.
Is that due to bleeding? Or just
Hip fracture is usually the immobility. It's not usually bleeding, it's the immobility for that patient. And it changes their lifestyle around, so it could be a VTE, a venous thrombose, embolectomy, and we'll have that blood clot. Which assessment data would the nurse expect in a patient diagnosed with osteomalacia? Lack of vitamin D, decreased bone mass, lack of estrogen, elevated blood sugar. Osteomalacia is the loss of bone related to the lack of vitamin D, which causes bone softening. We definitely need our vitamin D. We talked about that. This normal bone is disrupted. The calcification does not occur to harden the bone. So we would expect to have lack of vitamin D and a decreased bone mass because there's less bone. But A is the main thing that we're looking for in nursing lives. Okay, a patient was just diagnosed with Putrin's contracture. Which statement by the nurse is most common? It'll improve with time. The cause of this condition is aging. 4th and 5th fingers are most often affected. And this condition is never bilateral in nature. We know it can't be bilateral, right? And which ones? We know it's which fingers? 4th and 5th fingers. Who did we say this was most common in? Euro-Asian or Euro-American men. Okay, and it could be hereditary too. And what would we do to fix this one? Surgical release. That is the end of those. Questions on this portion?
Abby just called. She's just running a few minutes late. She'll make it by 11:40.
By 11:40, you said? So that means any word on pizza?
I can go downstairs and check.
If you would, please, that would be great. Thank you, thank you. It was supposed to be delivered at 11:15. I have a witness for what I ordered it for. Mm-hmm.